Hi y'all, and welcome back to Professor Truelove's Concepts for Nurses series, and I am Professor Terry Truelove. And in this episode, part of the respiratory concepts, we'll be looking at non-infectious upper respiratory problems, including neck and facial trauma, sleep apnea, laryngeal problems, and upper airway obstruction. Sources for this episode include Iggy's Medical Surgical Nursing and Soul's Introduction to Critical Care Nursing. Because this section deals with upper airway problems, the priority nursing intervention is always going to be to promote oxygenation by ensuring a patent airway. This is the A of ABC. Many of these conditions or injuries can sound innocuous. However, because they can affect upper airway patency, they can be quite dangerous, including a fractured nose. This is a displacement of bone or cartilage that can cause airway obstruction or cosmetic deformity. It is also a potential source of infection. If there's the presence of cerebral spinal fluid, this may indicate that there's a corresponding skull fracture. Interventions include closed reduction of the fracture, rhinoplasty, that is surgical repair of the nose, or nasoseptoplasty, also known as submucous resection or SMR. Patients with severe septal deviation may have chronic symptoms, including discomfort, and they may need surgical repair of that deviated septum. The nurse's responsibility after rhinoplasty includes observing for edema and bleeding, checking vital signs at least every 4 hours, and changing the drip pad as needed. Here we have an image of a person just completing a rhinoplasty. Although one of the adverse effects of rhinoplasty is a nosebleed, the term epistaxis refers to the spontaneous nosebleed. Very common, and it occurs because the nose is very well vascularized, has a lot of capillaries. This makes us susceptible to spontaneous bleeding, or epistaxis. Normally this occurs on the anterior portion of the nasal cavity, and we can cauterize the affected capillaries. We can also pack the nose. However, if the bleeding is on the posterior portion of the nasal cavity, that is much more difficult to access, more difficult to cauterize, more difficult to pack, and therefore is considered a medical emergency. You should assess these patients for signs of respiratory distress, the tolerance of the packing, or the tolerance of any tubes or drains. Provide for humidification, oxygenation, bed rest, antibiotics, and of course, pain medications. So of course, in epistaxis, the obstructive device is the bleeding or the packing needed to stop the bleeding. Nasal polyps are benign, grape-like clusters of mucous membranes and connective tissues. They may become large enough to obstruct the nasal airway. Manifestations include obstructed nasal breathing, increased nasal discharge, a change in voice quality. Most of these polyps are well managed with inhaled steroids. If required, surgical removal of the polyp, known as a polypectomy, is the treatment of choice. Another danger to the upper airway is posed by any type of facial trauma, in which the priority action is airway assessment. The manifestations include an upper airway abnormal sound called stridor, the evidence of shortness of breath or dyspnea, anxiety and restlessness, hypoxia and hypercarbia, decreased oxygen saturations, cyanosis, and even loss of consciousness. Your priority assessment is for airway. You should anticipate the need for emergency intubation, including things such as a tracheotomy, which we spoke of in a previous episode, a cricothyroidotomy, which is in a temporary airway by making a small opening in the throat between the thyroid cartilage and the cricoid cartilage, fixed occlusion, basically wiring the jaw shut in order to stabilize the mandible, and debridement, or removal of injured and dead tissue from any areas that are affected by the trauma. These are all things that can obstruct the upper airway. Another threat to upper airway patency is known as obstructive sleep apnea, or OSA. This is a breathing disruption during sleep that lasts at least 10 seconds and occurs a minimum of 5 times within an hour. Factors that contribute to OSA include obesity, a large uvula, a short neck, smoking, enlarged tonsils or adenoids, and oropharyngeal edema. Because muscles relax during sleep, tongue and neck structures may be displaced. This will obstruct the airway. However, chest movement is unimpaired. This causes a problem with gas exchange. These patients frequently wake up during these apneic periods, and this causes a lack of sleep. Signs and symptoms of OSA include excessive daytime sleepiness, the inability to concentrate, and irritability. Non-surgical management includes the change of sleep position, that is, sitting the patient up, encouraging weight loss, positive pressure ventilation, while surgical interventions may include a simple adenoidectomy, uvulectomy, or remodeling of the entire posterior oropharynx, which is known as a, ready for this, uvupalatopharyngeoplasty, or UPP. Both conventional and laser surgeries can be used for this purpose. A tracheotomy may be needed for very severe sleep apnea that is not relieved by more moderate interventions. Here are 2 images of the larynx being shown while they are vibrating, that is, while phonation is going on. And the larynx itself can cause an obstruction of the upper airway from vocal cord paralysis or from vocal cord nodules in polyps, essentially structures that obstruct the airway. Laryngeal trauma and damage can occur with a crushing or direct blow injury, a fracture, or even prolonged endotracheal intubation. Symptoms for disorders of the larynx include difficulty breathing, the inability to produce sound, that is, aphonia, hoarseness, and even subcutaneous emphysema. And to review that, subcutaneous emphysema is air present in the subcutaneous tissue. It looks kind of like little bubbles right beneath the skin, sometimes referred to as Rice Krispies. Maintaining an open airway is the priority. Upper airway obstructions are interruption of airflow through the nose, mouth, pharynx, or larynx. Because there is only one route, that is the airway, obstruction of this is a life-threatening emergency. Early recognition is essential in preventing further complications, including respiratory arrest and death. Factors that cause upper airway obstruction include tongue edema from things like surgery or trauma, tongue occlusion, that is, things like loss of gag reflex or loss of muscle tone, laryngeal edema, peritonsil and pharyngeal abscesses, head and neck cancers, thick secretions, stroke and cerebral edema, smoke inhalation edema, facial, tracheal, and laryngeal trauma, foreign body aspiration, burns of the head and neck area, and anaphylaxis. One of the most disgusting reasons for having upper airway obstruction that I've seen is known as inspissated or thickly crusted oral and nasopharyngeal secretions, which, in the case that I had, completely obstructed the poor patient's airway. So interventions for upper airway obstruction include to assess the cause of the obstruction and maintain the airway and ventilation, considering things like cricothyroidotomy, endotracheal intubation via nasal or oral routes, or even a tracheotomy if indicated. The Heimlich maneuver that you might have learned in basic life support is as a response to a foreign body upper airway obstruction. Lastly, the airway obstruction could be as a direct result of neck trauma. So your priority again is to assess for and maintain a patent airway. While thinking about neck trauma, however, assess for other injuries such as cardiovascular, respiratory, intestinal, and neurologic, because if there's trauma to the neck, that was a giant impact. That's a very strong force. There's probably going to be other problems, including carotid artery and esophageal injury, which could be swollen and cause upper airway problems. Also be aware that the cervical spine may be involved. And Because of this, the excessive neck movement that occurs with cervical spine injuries, that could also cause airway obstruction. The obstruction can occur from initial injury or from any swelling that results from that initial injury. And that does take us to the end of this episode, but hang in there. There are still more respiratory related episodes to come. As always, I hope you learned a little bit. I hope you plan on coming back to listen for more. And if you are, we'll see you then. Take care now.